Hi, I'm Dr. Andrew Rosen. I'm a psychologist.
And I am Dr. David Gross, and I'm a psychiatrist, and we are two shrinks in a mic. Today, we're going to speak about the use of medications in mental health care. We've alluded to medication and prescribing before, but we really haven't had a chance to get a discussion in depth about it. And both how you decide medications are necessary, as well as how does your therapist, who is a non-MD, at some point make a recommendation for the possible need for medication. So these are all the areas that we'll talk about as we proceed.
Yeah, it's a really important topic because for the average person who's going for any kind of help for a psychological, emotional issue, number one, the question is always, well, who do I go to? Do I go to a psychiatrist and get medication for this? Or do I go to a non-psychiatrist and get talking therapy for this? And the patient doesn't really necessarily know. Some of that will be influenced by a person's subjective feelings about taking medication. So it's a little bit complicated. I think for our purpose today, we're going to talk about it from the perspective of the clinician a little bit, because it's important for people to know that there's a little bit of a background history to how does a mental health professional know when to refer for medication or not. Historically, the psychiatrists and the non-psychiatrists were really worlds apart, even in terms of communication and ever really talking to each other. So if you as a patient went to see a psychologist or a social worker, very often that psychologist or social worker was not interested in at all with the possibility that a patient might need medication until down the road, if there was no progress happening or things were getting worse, then the clinician might pull the fire alarm and look for a psychiatrist to refer the patient to. That's not a very good method. And then on the other side of the coin, if the patient went to a psychiatrist first, whether it be for historically for therapy or medication, very often the patient would just stay in that realm and actually never get therapy, just would get medication. So fast forward to today, I think pretty savvy mental health professionals work closely as a team. So we've talked about this. The psychologist, social worker works closely with the psychiatrist and vice versa, so that there's less of a bridge to cross over in terms of seeing even a new patient and deciding, does this person need medication from the get-go, or should I wait a while?
You know, I wish what you're describing in this day and age was the case, but unfortunately, in our centers, it is the case. In our relationship over decades, like I called you the other day about seeing a mutual patient and to tell you what my thoughts were and what the plan was. But unfortunately, turf issues are still prevalent, meaning whether you're a master's level therapist or a doctoral level therapist or a physician level clinician, there's a desire to hold on to the patient, almost as if you can't share the patient, and that's absurd. But it's what it's been like in mental health care over the years, and you really wonder how often psychiatrists call the therapist to refer them a patient to discuss cases, and vice versa. The therapists in the community who I really respect are the ones who will send me an email or give me a phone call and say, let's discuss our cases that we haven't talked about for a while and compare notes and treatment planning, et cetera. But the turf issue is a real issue. The other aspect of medication is it's a bit of a dichotomy in that a lot of individuals will view themselves as really being sick if they need medication. Boy, do I have a major mental disorder, or I must be insane or out of my mind if I need medication. The implication of medication can connote very negative things for some people. Then the opposite is true, and that's why I say it's dichotomy, whereas some people kind of view medication as a quick fix and don't recognize that they need more than just the medication, that the medication can serve a purpose, but it may not take care of the whole picture. And frequently I will see somebody new who has had significant anxiety or life-related issues and secondary depression, and I'll ask them, have they been to therapy to learned techniques to deal with their anxiety and their overthinking and their worry, or have they been working with a therapist on dealing with their life situation? The answer is no. Instead, they just want a pill. And I tell people that, I'll be happy to prescribe for you to help you with A, B, and C symptoms, but it's not the whole picture, and you're depriving yourself of really moving forward in this whole process. And so medication, it's important to get an understanding of how a person feels about medication. And a lot of individuals I've seen over the years will say, I'm not a big fan of any medication, not just psychiatric medication, but the notion that I want my body to heal itself, and I don't want to take anything foreign into my body, which on the one hand has some truth to it. On the other hand, is a bit of an extreme approach. So it's helpful for me in the beginning to hear from somebody if they have anxieties about medication, because I know for sure they're going to consult Dr. Google if I recommend a medication, and before I know it, I'll be getting phone calls about, I'm worried about this side effect, that side effect, et cetera, et cetera.
Yeah, and from my perspective, when I first see a patient, generally speaking, I will get a sense as to whether or not this person is at all open to the concept of medication. But also, what I look for is to see how much suffering the person is actually doing symptom-wise in the beginning. Most of the people that I see are not suffering severely, so that their symptoms are somewhat manageable or very manageable. So that for that kind of patient, I said, well, let's get started with looking at what the issues are and seeing if you can learn how to manage your anxiety and depression. But for the patient who comes in and they're really not sleeping, they're waking up with massive anxiety, their appetite is impaired, their ability to even go out of the house or to go to work is significantly impaired. That's the person that really from the get-go, I have to let them know that regardless of how you feel about medication, we really need to consider it, because it's your symptoms are so significant that it's really going to get in the way of your recovery. And if we can give you something, even just temporarily, to calm those symptoms down, it will open the door for you to be better able to recover through the use of the therapies that we will do. So it's very important for the non-psychiatrist clinician, and we teach this all the time, to evaluate the current symptoms and don't just dismiss them as always amenable to therapy, because sometimes they're not. Sometimes the nervous system has to be quieted down enough for you to be able to provide good therapy protocol for a patient.
You're right about the symptom component. Study after study has demonstrated that in individuals with mood disorders, depression, anxiety, and insomnia, difficulty falling asleep, staying asleep, or even waking up in the middle of the night and being anxious and worried, that if you do nothing more than treat the sleep problem, their other symptoms will improve. It may not recover, but they will improve. And so the worst thing in the world is not being able to sleep. But looking at medications in general, they have tended to follow the advances in our diagnostic capabilities. In mental health, our diagnostic Bible is called the Diagnostic and Statistical Manual in Mental Health, DSM. And there are now 5 different versions, 5 editions of it, constantly changing. And that diagnostic Bible has depression diagnoses, anxiety diagnoses, and the medications, and I say this as a negative thing, not a positive, have unfortunately followed the diagnoses. So if you look at classes of medications in mental health, there are antidepressants, there are anti-anxiety agents, and there are antipsychotics. Almost as if these medications depend upon a diagnosis. And we're beginning to recognize that a better approach to this is more of a symptom approach rather than letting a diagnosis rule the day. And an example of that is if you talk to 10 individuals who come in with a diagnosis of depressive disorder, sure, they have sadness and negative thinking, but many of them, if not the majority, will have obsessive anxiety. I can't turn my brain off. I'm worrying about things that I shouldn't be worried about. It's like torture. It interferes with my ability to sleep. It interferes with my ability to have a helpful conversation with my friends and family. And so in those individuals, when we give them an antidepressant, especially a serotonin active agent, serotonin being one of the major brain chemicals involved in depression and anxiety. These medications like Prozac and Zoloft and Lexapro and fluvoxamine and Celexa, et cetera, have anti-anxiety, anti-obsessive benefits. And that's what gets the depression better, because you're treating first the obsessive anxiety. When that gets better, an individual begins to feel relieved, and they, over time, get less and less depressed. Antipsychotics have now been used as mood stabilizers, which I don't buy in completely at all, because I don't think they truly are mood stabilizers, but they can be helpful in the early stages of, for example, bipolar mania, in stabilizing somebody. But in terms of relying on an antipsychotic for long-term stability of somebody who has a mood swing disorder, I'm not impressed that the data is there. To this day, the gold standard is lithium. Unfortunately, lithium, because it's an element, if you remember your high school or college chemistry and the table of elements, it's right next to sodium as an element. It's mined from the earth. As a consequence, it's dirt cheap to produce, and therefore the pharmaceutical companies are not motivated to advertise it and get it out in the marketplace, because they're not going to make much money out of it. And so many of the newer antipsychotics that are out there, and you've seen all the commercials on television, have been pushed as mood stabilizers. As I said, I'm not convinced that that's the case. And lithium needs to be used more than it has been. But unfortunately, it's not taught as intensively in residency training in psychiatry as it should, because of the fact that all these newer, fancier, quote-unquote sexier agents that are antipsychotics are being pushed for this purpose. And so the take-home message from what I just said is that mental disorders, best to follow symptoms, as you're suggesting, Andy. And once you pay attention to the symptoms, it helps you better understand from a pharmacologic perspective what direction to go in.
And here's another example of very often a person, let's say with anxiety or depression, will come in and they have very, very negative thinking, catastrophic thinking, and it's obsessive as well. So they really, really can't stop thinking negatively. They have constant valued negative catastrophic thinking, all the what ifs, right? And the person can either know that this thinking is maladjustment and inappropriate, and they know that this negative overthinking is not accurate and they need to give it up. And they can even start to learn in the beginning in the cognitive behavior therapy some techniques, but their obsessiveness is so strong that they just can't stop. So they can know, I have to change that thought, but they'll come back to the negative thought like in the old days with a broken record, and they can't stop. It's not like they can hit the arm on the record player and it'll reduce or stop. And when it's that severe, when the negative, over obsessive type thinking is so severe and the thoughts are intrusive and day and night they don't stop, and the person is getting so tired from these thoughts, that's where medication can be very helpful and slow down that obsessive process. And then it doesn't happen overnight, but over a period of weeks or a couple of months, that it slows down enough for the person to be able to get their hands around this type of thinking and start to control it on their own. But it's a process. In the interim, if the anxiety is very bad, and we're waiting for the antidepressants to kick in, there's other medications that David can talk about, the anxiolytics, that calm a person down for those first few weeks. And again, give a chance for the therapy to take hold, and also, which we talked about, offer some hope to the person so that they could see, okay, I'm not better yet, but I'm starting to feel like I can get on top of this thing. So that's where the junction is between the medication and the therapy. Medication, I think mostly we could see in our work together, is there to help the therapeutic process along. Of course, there are certain disorders where, like with bipolar disorder, the medication is central, and in many cases can make a person fine even without the psychotherapy. But there has to be a good communication between the prescribing doctor and the mental health clinician who's doing the therapy. That's what we do all the time. I mean, I don't think there's a day that goes by where, at the end of the day, where we don't catch up on somebody. But in the real world out there, it doesn't necessarily exist very often.
There are the cases where, I'll refer an individual to you who's had horrendous panic disorder or obsessive anxiety disorder, which we call generalized anxiety disorder, and you'll get to see them and say, I can teach them the techniques in cognitive behavioral therapy, but the level of their obsessiveness or their panic is so great that they're not going to benefit right now. So for the person with panic disorder, oftentimes they need to have an agent they can use as a rescue agent to abort the panic attack when they have it, or the person with a horrendous obsessive anxiety will benefit from a serotonin active agent. And I'll tell them, look, this is the way you'll get the most money, most progress for your money, by being able to really benefit from the treatment, because psychotherapy requires a lot of work on the part of the patient's part. Medication is prescribed to a patient and they're passive. They just have to take the medication. But the other therapies are a totally different story. But the other piece of this puzzle around medication is something that I recall from my early days of training, which was I remember seeing individuals and trying to treat them, and they weren't making any progress, and I was either feeling like I was failing, or I was getting feedback from my supervisors that, well, you're just seeing resistance in the patient. Blame it on the patient, which unfortunately was old thinking and unfair thinking. But in terms of a non-psychiatrist therapist in the community making a decision about referring to a psychiatrist, it's often difficult because of feeling like, gee, I must be not doing my job, and I'm failing at what I'm doing. And so it's almost as if a black mark on yourself if you have to refer to a psychiatrist for medication. And as we mentioned a few podcasts ago, there also is the issue in the community of if you get a patient referred to you, holding on to that patient and not giving them back. It had been an issue for psychiatrists who would get a referral from a therapist, and they would end up doing the therapy and medication and basically stealing the patient, which is not right either. And fortunately, in our centers, we've had that team approach, which is a wonderful approach, where we're all part of the same therapeutic community, and the goal is to get people better the best that we can. But it's oftentimes difficult for clinicians who do the therapy to acknowledge the need to refer. And the ones that I value their input are the ones who will call me ahead of time and say, I've got John Doe or Jane Doe that I've been treating, and they're not making progress. And what they'll say to me, which I think is really a sign of wisdom, is they'll say, I really want you to get your 2 cents in terms of what's going on. Maybe I have misconception as to what the core issues are. One of the things that happens in psychotherapy is that you can get kind of stuck in the trees and not see the forest. That you may miss some of the bigger issues. And so we enjoy the collegial interaction by sharing cases and picking each other's brains and learning from each other. So just because you refer a patient for medication does not mean in any way that you have failed. It just means that you're a good clinician. It's like the internist who's treating diabetes, which they're able to treat, but finds that the person's not making progress and they need to, and therefore refers their patient to an endocrinologist. That's not a sign of failure. It's just a sign of good therapeutic thinking.
And to add to that, think about how the patient feels. Let's say the patient has been seeing this therapist for the last 2 months or 3 months or 6 months or whatever it is, and they're not really getting much better, or they may even be getting worse. And then finally the therapist says, well, I think I need to refer you to a psychiatrist because you need medication. Well, now that patient might have a bunch of feelings there, like, well, why didn't we talk about this earlier? But also, does that mean I'm too sick for you? You can't treat me, or you're not helping me because I'm really, really, really sick. So it conveys something that isn't true. It's not that the person has to be sick or sicker to be on medication. It's more that some people's nervous systems and biology can do better with a medication. And it's not a death sentence in terms of severity. It's just we can do this better with. And so it's just very important to have this concept of really it's a team. You don't always need both parts of the team, but it's important to consider the need for that in the beginning in particular. But even as you go forward, sometimes a person's doing better and better, and then you may find there are factors that are even beyond our awareness, just, some sort of time of the year or aging process or something where a person may be much better, but at this particular point may even need medicine to do and to continue to do better. So it's a whole different mindset that we have that some people are starting to have more of in the field, but it's definitely different than the mindset that has existed over the last, 10, 20, 30, or 40, 50 years. I'm going to stop at 50 because I don't want us to look too old.
Well, that is the case of having gray hair for
Yes,
sure.
and some hair.
The medication piece is an important piece, and I see a lot of individuals who had seen other psychiatrists for anxiety, depression, and before they know it, they've been in the meeting with that psychiatrist for 10, 15 minutes, and they get a prescription for a medication. But it's terribly important that you get a prescription for a medication plan. That is to understand why you're on this medication, what's the purpose, and most importantly, is this a medication that you're going to be on forever, or a medication that will have a limited use? I tell a lot of individuals who I see with obsessive anxiety disorders, panic disorder, etc., that I see the medication as building a foundation upon which you can do the psychotherapeutic work, which oftentimes is cognitive behavioral therapy, make the progress. And eventually you'll be retraining and reprogramming your brain. And so the medications that I'm giving you will not be needed. But people need to know that. It's amazing how many people I see who have been on a sleeping medication like Ambien for decades. They're now in their 50s or 60s, but in their 20s or 30s, they went through a rough patch in life and had sleep difficulty and got Ambien and were kept on it, almost as if the belief was that the sleep disorder was permanent, but it's not. A sleep disorder was transient based upon going through a stressful time, but nobody reevaluated whether or not that medication is necessary, and so before you know it, they've developed a physiological dependence on this medication, and after being on it for years, it's not easy to stop. What happens when you stop it after being on it regularly is you'll have rebound insomnia, which is not a return of your original insomnia, but instead is the brain reacting to the absence of the medication and getting into an activated, hyperactive state that causes insomnia. So getting a good plan as to why you're on the medication, how long you'll need to be on it. Does it indicate that this is a more severe disorder? Most of the time the answer is no. And it also indicates greater belief in recovery and hope. We've talked a lot about the concept of hope, and adding on medication to an individual's treatment plan is an expression of hopefulness and not a sign of, boy, you're in a lot of trouble.
One of the things that scares off a lot of patients in terms of medication is the fear of being an addict. And very often I'll have somebody say, well, if I take this, will I become addicted to it? And I make a very strong point to differentiate addiction from dependency. When you take a medication over a period of time, your body will get familiar with it, whether it's a psychiatric medication or cholesterol medicine or thyroid medicine or or any kind of blood pressure medicine. Your brain and your nervous system and the rest of your body become familiar with it and expect it. And so if you were to abruptly stop, yes, you'll get a message back from your body saying, what's going on here? That's not the same thing as addiction. Addiction involves craving. It involves wanting more. It involves, when can I get some more of this stuff? It's a big difference. And, what I'll say to my patients is, no, it's not an addiction issue. You've never been an addict. These medicines, some of them, some of the benzodiazepines in particular, we have to be aware of and monitor so that you don't have a dependency issue, but we're careful about it so that at some point, usually it's a soon thing, is to get off that particular drug, but it's not an addiction issue. And once that's clarified, most people feel more relaxed about the idea of taking medicine, but they may ask it about all kinds of medicines. And that's why some people really, as you said, David, hate all medicines. I have people who won't take the medicines that their primary care doc says for blood pressure or for cholesterol or whatever. Many people are afraid of medicines. It's the concept of, if I take this pill and I put it inside my body, I lose control as to what's going to happen to me. So that's scary for people. So there's a lot of work that I do for the issue of if a patient looks like they'll need medicine or at least a consult with you, or if they're on medicine, to help them deal with the fears and the negatives of being on medicine.
The other aspect of prescribing in psychiatry that makes it difficult is that if you go to your internist and you get some blood work done because you've been gaining weight and you're tired and you've got no energy and your pulse is low and you can't tolerate air conditioning, those are all signs of a sluggish thyroid, and the blood tests come back positive for hypothyroidism, which is a sluggish thyroid, you don't have any difficulty accepting that there's something wrong and that you need to correct it. Whereas when we're dealing with depression, anxiety, other people look at you and can't tell there's anything wrong with you, especially family and loved ones and friends. And that's part of the issue, which is it's harder to accept that there's an abnormality in how my brain is working that usually is transient, that needs to be addressed with medication. There's a form of the MRI called a functional MRI that actually looks at activity within brain areas in real time. So you can see hot spots, you can see spots in the brain that are not working as well. And so in anxiety disorders especially, we've been able to demonstrate that people with obsessive anxiety like OCD, you can see areas on the functional MRI before treatment that are overactive and areas that are underactive. And with the appropriate medication, you see normalization of these areas. I've wished for a long time if I to be able to have in my office a functional MRI machine. They don't exist, but if it was possible to have that, it'd be so much easier. It's similar to if you go in with a terrible cough and a fever and you get an X-ray and it's clear that you have pneumonia based upon the X-ray of your lungs. It's more objective, and mental health work is all subjective, which is part of the challenge for all of us. And so, as I've said before, and as you said before, one of our major roles is as an educator to help individuals really understand what's wrong and that it's not the end of the world and that there is a chance for recovery.
But again, I think the main takeaway we'd like you to have is that the work that's involved in overcoming psychological, psychiatric problems is, first of all, much different and much more effective than it was X number of years ago, where medications and therapy were either scary medicines and or the technique of therapy was one that was going to take years and years. So we're in a different place now. Therapy's more concise and brief and focused, and medications are definitely not of the nature that existed 30, 40, 50 years ago. It works. We help people, and the reason we love to do what we do and the reason we're here on our podcast is because we love to help people. And just like I said to a patient the other day who had been convinced they were never going to get better, and they just came back from a vacation with family and they were very happy, and I said, okay, this is my favorite thing to do. It's like, get ready. And they said, what? And I said, I told you so. My favorite activity is telling patients, I told you so. You can get better.
And it is a living, but we've been doing it for so many years. We wouldn't have stayed in it if it wasn't for the fact that people can get better. And otherwise it would have been difficult to maintain a career for decades like this. And I'm Dr. David Gross, psychiatrist.
And Dr. Andrew Rosen, psychologist. And this is Two Shrinks and a Mic. And we'll see you next time.
Bye-bye.
The Two Shrinks and a Mic podcast is for informational and entertainment purposes only. The views expressed are those of the hosts and guests and do not constitute medical, legal, or professional advice. Please always consult a qualified healthcare provider before making any medical or wellness decisions. Our content is not a substitute for professional medical guidance, even though our mothers tell us we have the best advice possible.